kind of the payoff for doing hard work and sort of understanding about CT reconstruction and projection slice theorems and all of that kind of stuff, to see how these images are used in clinic. And what I'm going to talk mostly about today is the use in cardiovascular applications. These are not, I wouldn't say they're common uses in the United States. They're becoming far more common in Europe, as CT is being adopted in Europe. But in the United States, there are some economic roadblocks. For instance, this technology is too inexpensive, which is an irony, but the problem is if you try and bill for this, you can't bill at the same rate as these alternative tests like nuclear medicine and echocardiography, which are more expensive. So if you're trying to make ends meet in a private practice, it's better to do those. Anyway, let's get started here. So, you know, this is an image, or you've seen this image before, of a heart rendered. So the number of pixels or voxels for this heart is 512 by 512 by 256. No, actually looking at this data, it's by 320. And each voxel is about a 0.5 millimeter by a 0.5 millimeter by a 0.5 millimeter, which makes it, you know, more than an order of magnitude more or smaller voxel representation than, say, magnetic resonance. And the details that you can see here far outstrip what you can see on, say, echocardiography. And nuclear medicine is basically just a fuzzy blob. Some of the details that are key to evaluating somebody's cardiovascular health are the you know, the resolution of these coronary arteries and what their physical diameter is as a function of position down the artery. If the diameter gets critically narrow at some point, say here, that is, you know, reachable by a catheter and a guide wire, you can open that artery with a stent if a person has an acute syndrome. And you can, you know, give a person a heads up that they're in jeopardy, basically, that if they start getting sudden pain in their left arm and in their jaw and things, it probably is one of these lesions that's getting them. This is the left coronary artery system. This is the right system. You can't see it. It's coming off the base of the aorta here. And you look at these tiny little descending, penetrating vessels that are going into the muscle tissue, which we're not really rendering here. This is, the muscle tissue has lower Hounsfield units, and basically I've just thresholded the Hounsfield units to make the blood, which has contrast in it, the prominent signal in this rendering. And so you can see the right coronary artery coming back to the back wall of the heart. This is towards the patient's spine. And then this vessel is descending down to perfuse that back wall. In some patients, you also have the circumflex artery is coming back around here and will also descend. And in fact, sometime in your fetal development, you usually have both, but then one of them dominates and the other one sort of shrivels up, unfortunately. I mean, you would think that, you know, a survival benefit of having two arteries feeding one location be a good idea, right? Redundancy is often a good idea. Anyway, that doesn't seem to happen in humans. And so this is, you know, the basics of the data. The remarkable thing here is that the gantry is rotating at about 4 cycles per second. You only need roughly a half gantry rotation to make an image. Right, so in 1/8 of a second, you obtain all of the information to create this volume image. And it's 1/8 of a second. In MR, to create a volume image like this, it would take 8 times 8 seconds, and the resolution would be much, much worse, right? So you'd get 8 basic slices, if you took 8 seconds to get each slice, right? So it's orders of magnitude slower. And so I showed you this before. This is the gantry, the sort of big iron hardware rotating. It spins up to its maximum velocity just for the acquisition, and then it spins back down again. And there's 256 slices this way. We've seen this before. That's what it looks like when it's getting installed. This is ours at the UCSD hospital. And I've shown you these pictures also before, and these are high resolution 3D data through the root of the aorta, and then that's a coronary artery moving through these adjacent planes as we move up and down through the body. And so I can, I stored this as a video, but you can move up and down the 3D image just by looking at these different planes. And the job of the physician is to follow, say, this vessel here. If you watch that vessel as it's going to, one branch will move off this way, another branch will come down this way. And the clinician watches those branches as they move away and looks for critical stenosis. And they just do this manually. They just ramp up and down through this data manually. You can, if the artery itself, so this is the left anterior descending coronary artery here, and look at the correlated noise on this. This is obviously not white noise, right? One of the reasons why you have this noise is that this image is actually reconstructed from cutting a curved surface through the heart such that this vessel stays in that surface. Or the surface, let's put it this way, the surface cuts through the middle of that vessel as we're moving along. And so you have this relatively smooth curved surface such that we can look at the profile of the vessel all the way from its origin at the aorta all the way down to, say, the apex of the heart. Normally, these curved surfaces, they only display, say, half of the heart or something. It gets a little weird if you go too far. And then, so we're looking along the diameter of this vessel this way, and we say, oh, this is about 4 millimeters, say this diameter. It thins down here where we have this branch, and the reason it's thinning down there, it could be that the thicker part is out of plane. This curved surface isn't perfect. But also there's this object here, and that stuff is, soft plaque here with a piece of calcium in the coronary artery wall. So we can cut these planes perpendicularly and look sort of at the axial view of the vessel. So as if we were in the pipe, riding down the pipe, looking down the pipe. And so here, this one is up here, right? So we have a nice, circular vessel. We can measure its diameter across here at about 4 millimeters. And then when we get to this plane, we still have a very broad opening of the vessel, but we see the lesion or the plaque. So this is the disease that we're actually looking for. And then when we look downstream, we see that that vessel has changed its diameter. It's become quite a lot smaller than it was here. And it's a lot smaller than it is even distal to this over here, right? So this is an indication that the vessel is a little constricted at this point. This would be a very hard place actually to put a stent because it's at this branching point, right? And so how you would get around this if this thing ever really got ultra tight, you'd probably put a bypass across that. If you have any questions, please don't be shy just to speak up, and I'll answer them as we go along. if we move that one plane here, so we've taken plane C and we're going to move it closer to this lesion and look at the really thin part. And we look, oops, sorry, and we look down here, you can see now you see part of the branch of the vessel, but also this very, stenosed or small opening leading into the left anterior descending. This vessel feeds the entire anterior wall of the heart. So all of the blood going to the anterior wall of the heart has to get through this little hole. So this person starts feeling symptoms, this would be a place that you would look. Again, here's the basically the ultra high resolution 3D image of that volume as we go up and down. You can see there's little bits of calcium here, beautiful depiction of the very thin aortic valve leaflets. And you see all these details in the heart wall here that are not usually appreciated in MR, certainly not in echo, and certainly not in nuclear medicine. And you can watch the right coronary artery here as it descends. There's a piece of calcium right there, which is evident even though there's contrast here. So why do we want more detectors? Say, why do we want smaller detectors to make higher resolution pictures? Well, if you're trying to find the first signs of coronary disease in a patient, such as calcium in the coronary arteries, you want to be able to see small, bright objects. And if they're really small, you need high resolution to see those objects. And here we see in this view, as I showed you before, the little piece of coronary calcium is probably 1 pixel. I mean, like its true dimension is probably around the volume of or the dimensions of a pixel in this image. And here it is from the orthogonal view if we cut through here. And so this is why if you want to see the beginnings of heart disease, in people in their 40s or even their 30s, to give them a heads up that, one day you probably want to go on a statin because you're growing these lesions. You need this high resolution imaging. A difference between a normal resolution scanner and one that has twice as many pixels. I think we've seen these before, right? And here's with a high resolution scanner, you can definitely see that lesion in here. It's sort of just a blurry bump. Same with this example. So one of the issues with imaging the coronary arteries with either X-ray angiography or CT is the radiation dose that the patient receives in order to make these really good pictures. It turns out now, because of the ability of these scanners to obtain the whole heart in one X-ray flash, essentially, that's 1/8 of a second long, you can obtain these beautiful 3D images with very low dose. Here's a person now, they're sort of normal body mass index of 27. The body mass index is a measure of your mass divided by your length squared. So it's to sort of how much mass do you have per unit length squared. And 35 is a very large person, 27 is normal, 24 is a very small person for these BMIs. And this is something that you pay attention to when you're doing CT, because it will change your choice of the radiation energy that you use, or the X-ray energy. So here you could use 100 kV because it's in the middle range. If this was 35, you'd probably go to 120 kV so that those X-rays have a better chance of getting through. And this person in these images, so that you can see the resolution and the image quality, signal to noise, this was obtained in under 0.3 millisieverts of dose. And recall that your absorption in 1 year of just being alive and walking around is 3 millisieverts per year. So this is 1/10 of the background radiation dose. So it's hard to, I think, claim that this dose is something that you could observe an effect from that in any type of risk of cancer. The other benefit of the fast-moving gantry, now that they've engineered these gantries to rotate so quickly, is that even when the heart rate is very high, and so this is this patient's EKG, and they have well under a second per beat here. It's probably 600 milliseconds per beat or something. And so this used to be a contraindication for actually obtaining the image. You wouldn't even try, because if you had to do some kind of helical acquisition through the patient that took many heartbeats, things wouldn't come back into alignment, etc. But now we can obtain all of our data in this blue stripe right here. And so you just pick a heartbeat, pick an end systolic time frame where the heart is contracted maximally, and you know it's going to be stationary for about 50 to 80 milliseconds during that time, and you take a picture there. And so with these high heartbeats, you can still get beautiful scans. And this is a huge leap in technology. And with the scanners that are coming out now, their gantries are rotating even faster. So we're going to go from 280 milliseconds per rotation down to 230. The big jump, sort of or change in life at that point is you don't need to have a drug lower the patient's heart rate in order to get a good picture. Actually, we spend some time on occasion waiting for the patient's heart rate to descend after giving them a beta blocker in order to get these super clear pictures. But that historically is what was done. But now with these new fast rotating gantries, the sites that have them are going away from that, and probably will go away from giving beta blockers at all. And then it makes the acquisition that much easier and more efficient. The other advantage of having these rapid acquisitions is that you only need a fraction of a heartbeat. And so if the patient's QRS complexes are coming at sort of random intervals, excuse me, you can still just detect a QRS and take your picture at a fixed time afterwards, right? You don't count on the synchronous behavior of the heart from beat to beat, which is an essential component of both three-dimensional echocardiography, of helical CT scanning, and of MR, because you average over these heartbeats, or you combine data over a number of heartbeats. With this, because we're doing it so quickly in a patient here who has, atrial fibrillation, and that's what's causing this, sort of massive oscillation or change in R to R interval, we can still do the exam and get good pictures. The other thing that CT offers that you can't do in, say, an MR scanner, or for echo for that matter, because of the crazy echocardiographic contrast you get off metallic devices. But this thing is an LVAD. It's called a left ventricular assist device. It's like an artificial heart. And it gets plugged into the apex of the patient's current heart, and there's a bypass, and it provides the pressure to eject blood into the patient's body. The reason you do it this way is like you can use the native valve structure of the patient. It's which sort of minimizes or diminishes the amount of red blood cells that get lysed while interacting with any kind of valve structure in the pump. But in CT, you know, this is basically a scout image on the CT scanner, and then you can see precisely how this device is placed and working and things like that, which obviously is not available with MR. We're going to look briefly at one of the main uses of cardiac CT up until now. And this application is good even with a slow CT scanner. Actually, it doesn't really have to be a fast scanner. But it's the prediction of your risk of having a heart attack, given you know, your age and your clinical history, and whether or not you have coronary calcium detected by cardiac CT. And it is recommended that you go on a drug called a statin if your risk of having a heart attack over the next 10 years is greater than 1 in 10. Okay, there's no question that if your risk is there, you should go on this drug. I mean, there are many trials now that have confirmed that statin use is very effective at bringing you back down to a normal risk level if you have high risk. And one of the primary risk parameters is the level of cholesterol in your blood. And so you can measure that with a simple chemical test. And if that cholesterol is really high, you should just go on a statin. That's it. But then when it's in somewhere in the middle range, the question of going on a statin or not is sort of open. And it's been shown over many trials and many years that cardiac CT, specifically calcium scanning, is able to define those patients who are growing lesions in their vessels. And you've seen those pictures of the lesions. You can see really small ones, very early ones. And it will modify your risk. This is some very interesting data that was obtained in a set of patients who had CT scans and were being evaluated for whether or not they should go on a statin, and not using the CT scans first. And what they were using first is this ASCVD risk calculator. And this calculator looks at a number of things, mostly LDL, which is your cholesterol, your age, blood pressure, your history of drugs, etc. And there's really about 10, I think, variables that go into this risk calculator. And so when they looked at the patients who were eligible for statins, right, they subsequently looked at those patients on CT scans, right, and they what's given here is the classification of those patients by the CT scan. And so these patients on the CT scan had absolutely no coronary artery disease at all, okay? And by the ACVD risk calculator, 30% of them qualified for statins, right? And should have gone on statins. It's probably true that these people should be on statins because more than likely their HDL was high, and that's what prompted them to be in that group. It gets interesting when you come down here, not with the people that were proven to not have disease, but with the people who do have active disease. And in the group that on the CT scans show, the CT scans showed that they did have coronary lesions that were ongoing and growing. Only half of them qualified to go on a statin, right, by the traditional metrics. So these folks who were growing these lesions were left off the statin, right? And the a question there as well. I don't know. A statin's a pretty low risk venture. Why don't you put these folks on statins since they're shown by imaging to be growing these lesions? And then this group are the group that have obstructive CAD. That means their lesions are quite severe. And so, they have extremely tight coronary stenosis. More than likely, 15 years ago, you would have treated them with stents. Not so much anymore, but, and only 13 out of 20 of these folks qualified to go on a statin, right, with clinical metrics. And so these folks with these highly obstructive lesions, are left out in the cold. And that's ridiculous, right? So the question there, like, why don't you include these data, right, to advise whether or not these people go on the statins? And another trial using cardiac CT, and this was a very big, expensive trial in which they randomized 10,000 people, and they put them down two pathways. One pathway, the patients had a CTA as their first thing that they had, which was a coronary cardiac CT scan, something like here. And then the other half of these 10,000 patients went down a traditional cardiology workup. And that usually means a nuclear medicine stress test. And you can see what a nuclear medicine stress test looks like there in the picture. So these folks, what you really look at is the perfusion of the myocardium, if you can. And if there's low perfusion, this orange stuff will go to a lower number, cold, and you call that a positive perfusion scan. And so this patient looks like they have a drop in perfusion when they're stressed. You usually stress these folks either on a bicycle or you give them a drug, like to open up the arteries so that you have maximal blood flow or maximal demand. No stress done over here. This is just resting scans in a CT scanner. So the first thing to notice is, the same number sort of went in the top. 400 of these patients out of this number were positive enough on this test to recommend that they go into the X-ray catheterization lab. And in that lab, you put a catheter up, their femoral artery through their aorta, plug it into a coronary and squirt dye down the coronary and look to see whether or not they truly have a tight vessel or coronary stenosis. So 400 out of this group were sent to the cath lab. When they got to the cath lab, 213 of this 406 were found to be absolutely normal, right? So 193 out of this 406 were found to have CAD. So they actually had disease. So basically this thing sifted out your group such that now you can basically flip a coin, right? It's a 50-50 shot whether or not those people are abnormal. So what's the harm in that? I don't know if it's a lot of harm. It's just 200 people got a cath they didn't need. So it's expensive, and there's some risk involved. Over here, when the CTA was looked at, 600 people out of this qualified to go into the cath lab, okay, to look for tight lesions. When they did the cath on these people, 439 had lesions. And you look over this number and say, well, wait a minute, 193, 439, there's quite a difference here, right? And these two groups are identical. So these two numbers, if these tests were identical, would be identical. So you've uncovered a lot more disease here. Granted, you still have 170 people who you thought were positive, that would be positive on cath, that turned out to be normal. So that's a problem. And in fact, as engineers and physicists and imaging people, this is our job, right? We got to figure out how to make these pictures better so that this doesn't happen, right? Why? First off, you look and say, why did a radiologist look at this picture and think there was a lesion there, and then when they got in the cath lab, there was not? It's a pretty simple thing, right? So that is it's sort of an ongoing pursuit as to how you get rid of these false positives. Because as you can see, we sent a lot of people to the cath lab versus this branch, right? When they got to the cath lab, and you say, well, what happened in the cath lab? Was there a difference in outcome? Well, twice as many stents were put in, 236 over here versus 120. And twice as many coronary bypass surgeries were done in this group versus this group, okay? If I'm looking at this as, different interested parties, these data mean different things to me, right? If I'm looking at it as a patient, I probably would like to go down this pathway just so that I don't get lost, right? I mean, 193 to 439, a bunch of people in this box have coronary disease. And in fact, going down this pathway, if you're my age, you have friends who've gone down this pathway. And I have 3 close friends who went down this pathway, 2 of whom were put in this green box, not in this trial, but just in general. They said, oh no, your SPECT is normal, you're normal. And they both knew they weren't normal, both of these people. One was a cyclist and one was, he wasn't a huge athlete, but he knew he wasn't normal. But the cyclist guy, he said, look, I just can't ride as far. I feel kind of nauseous, blah, blah, blah. And so they finally took him to cath, and he had 3 massive lesions, right, in his coronaries that they subsequently stented, and he can bike again. So that's the problem with this pathway. It restricts people from getting down this pathway. If you're let's look at it from the point of view of, say, Medicare, or for that matter, Humana or Blue Cross, like some insurance company, right? Which one of these pathways looks better? It's not a trick question, right? All of this stuff down here is cost, right? And so this pathway, if it's acceptable, is obviously going to be the higher bottom line pathway for an insurance company, right? And insurance companies run a lot of medicine in this country, right? So this is a slightly disruptive thing. One of the outcomes of this study, which was kind of a joke in some ways, is that the 2 pathways were evaluated by all of these really highfalutin academics to be equivalent, right? And the reason they were equivalent is because the number of deaths on this side of the pathway and the number of deaths and hospitalizations on this side of the pathway were equal. And they were very small. They were much, much smaller than they had anticipated given historical data. The reason for that has become quite clear, and that is that modern drugs and the modern drug regimens are very good at keeping people alive, right? And so to detect a difference in these 2 pathways, you would have needed a lot bigger numbers here, right? Because this is the only delta difference in those pathways. And so, you just didn't have it. So it wasn't really powered well for that. However, it certainly, gives you a understanding of the different sensitivity of these 2 techniques. So given that data, and given all of the historical calcium data, this is a group at the Department of Health and Human Services called the U.S. Preventative Service Task Force, okay? And they recommend things that should be done in medicine, right? And so the one question, they had a big, panel, and this is from 2009. It's like, how should providers approach screening in patients at increased risk of heart disease? And they basically came to the conclusion that even with EBCT, which is electron beam CT. We didn't get into that, but ECG or anything, they say, well, we shouldn't really screen normal people for heart disease, because what you'll do is you'll find a lot of heart disease, and or you might have false positives and send people down a complex pathway, and it would be more harm than good. But this statement was the one that I really liked. It says, reasons to consider screening an individual patient. So now forget about the population, right? Well, let's look at individuals. Which individuals should you possibly screen for a particular reason? It says, select occupations such as pilots, where sudden incapacitation or sudden death may engender the safety of others. So you just let that statement sit there for a minute. You go, what? So you're telling me that all of the scientific data has proven that it can find evidence that a person is at higher risk for a heart attack, but we should only do this in pilots, right? Well, wait a minute. Who's the pilot? Like when I'm driving down the 5 and I've got my family in the car, who's the pilot now, right? So I kind of want to be in the pilot group. The ironic thing about this is if you asked 100 pilots who would like to undergo a screening test, you know how many pilots would say, yes, I'd like to undergo a screening test? Absolutely zero. Because the pilots, the last thing they want to do is lose their job because they've got a positive test. Any questions on that? No? Okay. So what do these things look like? Here's a coronary vessel on a CT. You know, it's got, I don't know, about 4 millimeters of diameter. And then as we go along, it gets narrow, right? And then it goes back to its normal diameter again. And that's called a stenosis. And this is what it looks like in the orthogonal view from this one. And, you know, so it's not just in one direction. It's sort of a cylinder that its diameter changes as it goes through here. So we get an hourglass shape. So you can now draw a line right through the middle of that stenosis. Whoops, sorry. Right through the middle of that stenosis and look at it in cross section. And you can say, take a caliper, a digital caliper, and measure, you know, the diameter of that vessel. And let's say it's 1 millimeter. So therefore, you know, that's a 75% lesion, right? It went from 4 down to 1, right? However, this process is never done by clinicians. They never draw this caliper. And I think looking at this picture, you can kind of understand why, right? Is that, you know, where do you draw it on this thing? I guess you could draw it on the half height, you know, that's one way you could do it. However, when these things get small enough and they're, you know, smaller than the full width at half max of the point spread function, all you're going to see here is the point spread function, right? You're not going to see a changing diameter. The only thing you see is the amplitude of the signal goes down and the shape stays the same. And so experienced cardiologists and radiologists who read these things don't do this, right? They don't get out the calipers and measure that. They look at the whole picture and they look to see if that signal is getting dimmer, right? If it's actually getting dimmer, then they know you might have a critical stenosis on your hands. The other thing you can do, and this is something that was FDA approved about 5 years ago. It's become a standard technology. We do probably 2 of these a week, 3 a week at UCSD, where if a person is, it's not clear, absolutely clear that they're normal on their coronary CT, you take the CT data and you segment out their coronary vessels. You look at the total mass of their myocardium, which gives you an indication of how much blood should be coming down those coronaries, right? So if their mass is twice as big, you need twice as much flow. And then you look at the geometry of the vessels themselves from these segmentations. and run a essentially large 40 fluid simulation, right, to get all of the blood flow in this geometry. And then you measure the pressure drop as you go down the vessel from that large simulation, right? So, there's a large history of computational fluid dynamics in many applications, not just coronaries, but also in large vessels, et cetera. And though that technology was just transferred to this application. And it was, they formed a company, the folks who did this formed a company called HeartFlow. Oops. And so here's a couple of outputs from HeartFlow. These are cases that we did early on at UCSD to check out this technology. And here's the color map gives you the pressure as we go down the vessel. And you can see there is a stenosis here, but the pressure drop from, this would be 1, there would be no pressure drop. Down to here, it goes to 0.87. The pressure drop isn't that great. Turns out that if that pressure drop goes down to 0.8, that has been an accepted threshold to determine that this lesion is actually causing a significant flow abnormality, and it should be stented. And this was done in the FAME trial that was performed in France. I forget if I have slides on the FAME trial, but we'll get there if we do. But this can be done non-interventionally with CT, and this is shown to principally provide a way to keep people out of the cath lab who are more likely to be normal when they get to the cath lab, right? And so if you remember from the slides back here, this was a problem, right? The fact that we had 609 cases got called positive, and when we got to the cath lab, 170 were not. This technology is a way to make, let's see if we can get this 170 down to, 70. And so this patient, even though they have this lesion seen on their CT, this type of computation tells you it's probably insignificant.
Hey, Professor, I've got a quick question.
Sure.
Do you know how HeartFlow does their boundary conditions? Is it like patient specific, or do they just do like a general like velocity profile to start those simulations?
Well, it's absolutely patient specific in the sense that they have the patient's vascular geometry, and they have the patient's myocardial mass and how this vascular geometry is feeding that mass. Now, whether or not they start, with a specific velocity field and then iterate from there, I don't know the details of that. But it would be interesting to know actually how sensitive the delta pressure is across here to whether or not you started that at the right level, right? So
Yeah.
the key parameter here is this pressure drop. That's the whole thing, right? So if you move the simulation up or down in velocity, say 10%, I'm not sure it would change this by that much.
Yeah, because they're just looking at like the proportion of pressure drop and not like super detailed like flow fields or anything, right?
Well, yeah, correct. I mean, as long as that pressure drop is correct, the flow field itself, whether or not it has a vortex, whether or not it has a, it's straight, etc. It doesn't really matter. But they've written about, when they were academics, they wrote a bunch of papers on this stuff, and the principal determinant of this pressure drop was this geometry. So you really want to get that local geometry, specifically the rate, this diameter across the stenosis and this diameter across the normal part. You really want to get those right. and they showed, the sensitivity to getting those wrong, or the sensitivity in this number to getting those wrong. And it was fairly robust, right? And now the really cool thing about this company is they started, I guess, in 14 or something like that. And, the employee number 2 was one of these early deep learning guys. And so their model was, and still is, you take your patient data, which is a full 3D, block of data. And it's like 256 by 256 by 512 by 512 by 256. And you upload it to their server. And so they take it in-house, and however they do it, and they've probably iterated through many ways of doing it. They first segment your data, right? And they get back to you as to whether or not they can do that well with your data. If you give them crappy data, they'll just send it back.
Yeah.
And so over the years, they've done that. And then they run this computational fluid dynamics on your data, and then they send you back this map that you're looking at right now. It hasn't changed that much. It still looks kind of like this. But over the years, obviously, tens of thousands, now hundreds of thousands of data sets have gone through that place, right?
Mm-hmm.
And outcomes are known in a lot of these things. And so, as a way of building up a huge training set, they've got it, right? So my guess is that now they drop the CFD part. They just run their deep learning model on the data.
That's really cool. I think I'll look into that. Thank you.
Yeah, it's a really neat company. They probably are still hiring people because they've been growing really fast. Because they a brilliant strategy. If you have a high-tech company like this, high-tech device or imaging company, one of the things that you have to spend a lot of money on, not just research, is you have to get people who knock on every darn door in the markets that you're trying to sell this thing. And the doors are the insurance companies. And you have to sell it to the insurance company, and you have to get them to agree to actually reimburse people, right? If they're going to do this trial. And the physicians aren't going to talk to the companies about that. Or the insurance companies about it. So anyway, they went and they got Blue Cross and a bunch of places they connected your ability to do this calculation with any kind of reimbursement for coronary CTA. So Blue Cross would say, oh yeah, you can bill us for coronary CTA, but you can only bill us if you have the ability to do heart flow. You don't have to do heart flow. You just have to have the ability to do heart flow. So this was a brilliant move, right? In the sense that everybody got it, because in order to bill for any kind of coronary CTA, you had to have this in your back pocket. So, and it really does do what it's advertised to do, and that is in those patients who are equivocal, you don't know whether you should call them positive or negative, right? You just push this button and the data goes sent off to them, and they come back and they make that decision for you, right? By giving you this number. So it's a pretty cool product. And I think this is that patient, and you can see this large, it's actually a very large vessel to begin with. And its stenosis down here, and there's some kind of aneurysm by the look of it here. But this patient, you're not going to do anything with that lesion for sure. You just leave it alone. So there's no point actually in taking them to cath lab. Here's some other cases where you have a tighter lesion here, and it also has, soft plaque here plus calcium, right? So it's an interesting looking lesion, and then you see that the pressure drop into this region across this lesion goes down to 0.8. And so you would say this one is positive, right? Let's see what time we're at. Sorry, I got pull out mine. All right. And this is a demonstration done on a computer simulation of imaging small cylinders. Here's the cylinder is running perpendicular to the scan plane, the diameter of 3 millimeters and a certain amplitude. And then as the diameter of that cylinder, much like a coronary stenosis, gets narrower, two things happen. The circle gets smaller, but then in fact, the circle doesn't get smaller, it just gets dimmer, right? And the reason is once you hit the point spread function, like the fill width at half max of the point spread function, which on most scanners is, when you couple them with the kernel, the image reconstruction kernel and the spot size and everything together, it's usually around here, is the point spread function, somewhere in there, maybe even up here. And so all of these are essentially the same diameter. It's just they get dimmer because there's a volume averaging of the amount of bright contrast in the dark background. So as a clinician, you have to learn to read this, right? They get dimmer more quickly if they're moving at all, right? So small objects don't have to move much in order to decrease their signal. And so if we look at this one here, these two cases, you say, well, it's probably about 1 millimeter if it was perfectly stationary, but it looks really dim. So it looks more like, it's a more severe lesion. And so this could be another reason why lesions were getting called to be more positive than they probably were, leading to those false positives. But you can do motion correction in CT and then get back to the normal signal intensity. And so we didn't look at motion correction, but it's possible. This was, we had these phantoms, with coronaries in them and stuff. And then this motor here drives it back and forth. And this is the same motor that drives an optical stage. So you can move it exceedingly precisely and in very small increments. And so to characterize what happens to a signal that looks, say, like this or this when it's under motion, right? And this is the type of motion you would see inside the 160 milliseconds that you would be taking your CT data, right? And so this, it leads to algorithms for correcting that motion such that you can resolve the picture of these tiny things much better. And this is a really interesting subfield in this, and it's basically called plaque characterization. And so you're looking at phenotypes of the plaque, right? And here we have, a patient that has, some coronary calcium here. There's a little chip of calcium here in soft plaque. And here is a plaque which has no calcium, but you can see it comes in towards the vessel and it is positive remodeled, it's called. I don't know if I'm imagining it, but you can probably see that signal there. And this, is called soft plaque. And it actually turns out to be just as dangerous as this, if not more. And then there are some patients, especially older patients, people in the 65 and older, who have just developed a horrendous amount of calcification in their coronary arteries. And they can live just fine with that calcification. In fact, it might be slightly protective in terms of acute events right here. However, the amount of calcium a person has tends to put them in a higher risk category. And principally, I think is because they're just, showing I'm growing lesions. I have a inflammatory process or something going on that requires me to repair this vessel a lot. And therefore I'm at higher risk. And then some of these other features, this is a particularly interesting one. This is called napkin ring sign because it has this bright halo here. This is the lumen of the vessel, and then you have this very dark signal right next to the lumen of the vessel. This is thought to be the lipid core of this large coronary lesion, right? The lipid core with a very thin plaque wall here is thought to be quite dangerous in that if this tears in any way, or if you get a tear in this, you will get instant thrombi right here, right? Because some of this stuff will leak out and you get this major thrombus. And so this is thought to be quite unstable. And so these kind of plaque patterns, whether or not the calcium looks like this, or does it look like these little spotty things, people are trying to compute these with machine learning to create a map of which one of these gives you the best prognostic value, right, for whether or not a person is at higher risk of having a coronary event. The next thing we'll look at is the function as measured with CT, and the simplest way of doing this is just to take two images, one at end diastole when the heart is full of blood, and the next, about 250 milliseconds later, when the heart has contracted to its maximum and has ejected the most amount of blood. And this is called end systole. It's roughly 35 to 45% through the heart cycle. And this is end diastole, which is when the muscle has relaxed and pulled blood back in. And you can get an ejection fraction, which is a classic measurement for cardiac function. And that is, what is the ratio of the blood that went out, so that's this minus this, divided by how much you started with, like what percent got ejected. And that's called ejection fraction. It's a very blunt statistic, but it's kind of sums up how you're doing. And there are many indications in medicine that require that the ejection fraction has to be below a certain threshold before you can consider doing some kind of intervention. And so 35% is ejection fraction is usually considered a pretty good cutoff, such that if you're below 35%, you're pretty sick and you're in heart failure. And so you qualify for a number of different types of therapy. Obviously, we can measure this extremely accurately and in one heartbeat, right? It's like bump, bump, we get two pictures and you get that number. If you make 10 pictures instead of 2, you can get a data set that looks like this. And this now looks at the complex dynamics of the atrial contraction, which occurs first up here, and then the ventricular contraction. And you get to see the local dynamics of the motion of the heart wall during that contraction. And you can see the ejection fraction of all of the chambers, the left atrium, which is here, the left ventricle, which is here, the right ventricle is not shown in this, and the left atrial appendage up here. And so it's, you can do a lot more than just ejection fraction. You can look at, the temporal nature of that contraction. And at each one of those points, you can, measure the volume in the left ventricle and plot out this volume curve. And so you can measure gradients for how quickly is blood being ejected from the heart, how quickly does the tissue, or easily does the tissue relax to come back to its more full, state. And it turns out this slope here is really indicative of normal myocardium or myocardial health. If this slope turns out to look like that, where it looks viscous, it takes a long time to relax, that is an indication that a person has a condition called dilated or hypertrophic cardiomyopathy, which means like a thick heart. It's not so much the heart dilates, that's incorrect. It's that the wall itself is starting to get thicker and more viscous. And so it's a special type of heart failure. And probably the best indicator that you're going down that route is that this slope, is diminished. This is what the inside wall of the left ventricle in a human looks like. So this is the left ventricular chamber filled with a transparent fluid, which is oxygenated so that this thing is working, although for some reason the movie didn't come over. But you can see all of these like, details here, and this is called trabecular tissue. We can actually measure that tissue on CT. We have the spatial resolution to actually look at how that tissue collapses and contracts during normal cardiac function. And we figured out a method for measuring the relative amount of collapse or contraction of this pattern as a function of position on the ventricle to quantify normal contraction versus abnormal contraction. The other thing you can see here, I love this case where you see the atrial appendage aggressively contracts, right, and ejects probably more than 50% of its volume into the left atrium on each beat. And this little sucker is a dangerous little chamber, in that if you have atrial fibrillation, blood comes in here and kind of stagnates in there. And it's been estimated that 80% of strokes in people who have atrial fibrillation come from thrombi that were generated in this chamber, right? So there are actually methods for just pinching it off so that blood cannot come back out once, you stop blood coming in and out of that chamber. But with CT, you can measure this ejection fraction, you can measure its dynamics, you can actually measure how the contrast flows in and out, which is pretty cool. I'm going to sort of skip through faster. Where are we here? 1205. Excuse me. So here's the two surfaces, at end diastole when the chamber is full, and systole when the chamber has contracted down. We track one surface onto the other using classic, computer vision techniques. And you get a vector field of displacements to go from this surface onto this surface. And here's those displacements over time. And then using that, we can calculate how the tissue clumps together or squishes together when it's normal. And then you can see there are some regions where that tissue is not squishing together. In fact, it's getting pushed probably farther apart and it's stretching. And so we measure this amount of contraction, as a sort of a percent change in linear dimension. Sort of, it doesn't have directional sensitivity, but it's a linear dimension in this patch. And so it contracted down by 30% to get to 0.7 here. Whereas up here, see, it's yellow, so it's 1.1. That means this little patch here got stretched during normal cardiac, or the cardiac contraction period. So this is not normal, right? That should be contracting. We did a bunch of validations on this stuff. I'm going to skip through that. Okay, you can measure that contraction as a function of position on the left ventricle. And for each one of these positions that we have marked here, say this region here, you break this surface up into 16 patches, and then you can plot a graph showing the amount of contraction inside each patch. And this is over 25 normal people. That's basically the functions that we measure in those people at this location. And this is the mean of that and the standard deviation. And then you can use that to test whether or not somebody has normal function, right? With this red curve here, giving you the function in the single patient, and you compare it to that group of normals to decide statistically whether or not that person has an abnormal left ventricular function. This, I'm going to skip across that. This is, okay. What's done here is called dynamic perfusion. And is that going to play? Doesn't look like it's going to play. I'll show you another one. But you inject contrast, you watch the contrast go into the ventricular chamber and into the tissue. And do I have, oh, here you go. So this is what a sequence of CT pictures, exceedingly low dose CT pictures, right? Because so you can see how noisy and blurry they are. That's because each one of these is a tiny fraction of dose. But what you can see is where the contrast is going in the cardiac chambers. So it first comes down the superior vena cava, right? Goes into the right ventricle and then comes out the pulmonary artery. That lights up next. And then the thing that lights up after the pulmonary artery is this, one of these pulmonary veins into the left atrium. And then that is how the blood flows into that thing called the left atrial appendage, right? So it starts at the top and it sort of makes its way up there slowly. And then the blood comes out the ascending aorta and the descending aorta. So these dynamic variables can be measured to characterize both flow into chambers and also perfusion. I think, did I not have? I thought I had a slide showing the relative perfusion in the tissue, but you just measure that intensity as a function of time, say in this part of the tissue, and it should give you, or you can calculate the actual perfusion of that tissue or blood flow, given the dynamics. Now, the issue is you're taking many CT pictures to get this data, right? Remember when we do a coronary CTA, we only had one of these, and it was a very low dose. Here we're taking a set of these scans, so each one of them has to be super low dose in order to generate these curves over time. And one thing we've started to look at also is, can you look at the function of the left atrial appendage and the left atrium? And the reason is because the way they do it now to sort of sort people into high risk and lower risk for developing stroke with atrial fibrillation is they use a thing called the CHAD-VAS score. And this is your age, sex, congestive heart failure history, hypertension history, stroke, vascular disease history, and diabetes. None of these things look at the left atrial appendage, right? Which is where the stroke happens. They're just sort of clinical correlates to all of this. And so what you're trying to decide is, should I put this old person who is 74 on a blood thinner like Coumadin, right? And the reason you have to stop and wonder whether you should do it is because they're at a much higher risk of having, say, a bleed in their head, you know, when they're on Coumadin, or having, or, you know, if they fall down the stairs, having a very dramatic bleed in their body. And so you don't really want to put them on Coumadin if you don't have to. Now, if you're avoiding them developing thrombus in their left atrial appendage, then it's probably a good idea. And the current technologies to do this, they look at echocardiography, and they look at the velocity of the blood as it's ejecting the left atrial appendage. So let me give you a map of what here's the left atrial appendage here, right, on CT. You don't see it like this on echocardiography. But they measure a little spot over here and they ask, well, what's the velocity of the blood as it's coming in and out of here, right? Perhaps high velocity is good. That means the blood's moving in and out, and low velocity is bad. And so when you measure it, here's the velocity of the blood coming in and out of the left atrial appendage. This is the left atrial appendage ejection fraction. And that means like just how much, what percentage of blood is ejected. This is probably a better thing to measure in terms of its function of the left atrial appendage. And you can see the velocity can be anything at different ejection fractions. So this is an interesting example of scientific papers in that the authors published this graph in this paper in order to make the statement that the left atrial appendage flow correlates with the left atrial appendage ejection fraction. And I use this graph to say, this does not correlate with this, in that it's just a shotgun blast of values. And we need something better than this, right? And so that's why we started looking at CT characterization of the left atrium. This is the left atrium, all the pulmonary veins here. You can see how it's moving and the dynamics of its contraction, you know, and here you can see the actual details of the ejection fraction of the left atrial appendage. Here's the left atrium up here. And so this seems to be a much more sensible thing to measure in these patients, in my mind. And as I just showed you, this is the dynamics of how the blood goes from the left atrium into the left atrial appendage, the dynamics over time. You can see this distal part lights up quite a bit later than the proximal part, right? So here, the blood has come from the left atrium into the orifice and the origin of the left atrial appendage, but it takes a number of heartbeats, right, before it's gonna, sorry, there's something in my way there. You see that? And then it stays there, right? So the blood is still up there. And so this, whether or not this correlates with the probability of having a thrombus in here is still under investigation. We're trying to look at that. And oh, yeah, here's what that injection looks like in 3D, right? So this is the superior vena cava. Stuff comes down here, then goes out the pulmonary artery, then lights up. That is the left atrium, and then this little ditzel right there is the left atrial appendage. That's lighting up here. It's got a really odd shape, right? You know, look at that. Yeah, so this is pretty cool. And then you can actually see the recirculation right at the end. There's a flash up here, like right there. That's after all the blood's gone through the body and coming back, right, into the superior vena cava after it's traveled around once. And, you know, we can segment out the left atrial appendage in these patients. And you see it really isn't doing this contraction anymore because this atrium is in atrial fibrillation. So we can measure, you know, these are our first shots at these segmentations here. We can measure this very precise volume of how much blood. This is all passive now, right? The blood gets pushed into the atrial appendage and then it gets ejected out passively. And so trying to characterize that relationship. If the patient looks like they're at really high risk for developing a thrombus, you can stick a thing, it actually is covered with a type of cloth, and you put this closure device into the throat of the left atrial appendage. You'll open it up and it attaches to the walls, and then it just seals it off, right? And grows epithelium on the other side of the closure device. Okay, so there's a whirlwind tour of cardiac CT or applications of CT in cardiac. Hopefully it's clear why you want high resolution, why signal to noise is important. For example, in those left atrial appendage flow movies, you know, if you're going to take 20 of those to get the dynamics, each one of those pictures has to be taken with a low number of photons. And so some kind of noise reduction processing is probably warranted for that application. And then it goes all the way to determining, you know, the features and the really high resolution features of these plaques, right? And this thing across here is like 3 millimeters from here to here and here to here. And that little ditzel there and that ditzel there is a fraction of a millimeter, right? And so you want these super high resolution pictures there, and dose, depending on the patient's age, may not be as big a deal. So hopefully that was interesting. And on Wednesday, we're going to start with MRI.